Hi, I'm Dr. Sazali Basri from the Malaya Medical Center, calling to Malaysia. Today, I'll sharing two cases to illustrate on switching ART therapy in year 2022. Let me start with our first case. Here we have Mr. A. He was diagnosed with HIV in years 2018 at the age of 20 years old while he's studying in overseas. During that time, he was presented with sore throat, fever, and weight loss, and subsequently diagnosed with PJP, complicated with pneumothorax, and he was started on treatment, although it's complicated with bacteriology. His NADA with CD4 was 30, with baseline water load more than 700 copies per mil, while the baseline genotype testing showed wild-type HIV-1 virus with no resistant mutation. His baseline Hep B and C were negative, and he subsequently started on APACC, 3TC, and DTG. However, developed allergic reactions a week after the initiation of ART. The switch to combination of PEF, FTC, albuterol, and cobicistat, and he's able to achieve biological suppression with this ART regime for about a year. A year later, we noticing that his water load start to climbing up and start failing on these ART regimes. So our next question is, what would you do first? First, of course, we need to identify the cause of the water failure. Most commonly is due to non-adherence, due to either the side effect of the medication, financial issues, pill burden, or underlying mental health disorders may impede the compliance to the ART. After addressing the issues, our next question is, which ART regimen would you choose? Based on DHSS guideline, for someone who were failing on INSTI plus 2 NRTIs, the best option would be boosted PI plus 2 NRTI, in which at least one of the NRTI are fully active, or either combination of boosted PI plus INSTI, or BD, DTG, or possible bictegravir plus 2 fully active NRTIs. So would you do HIV test in him? Basically, it is not recommended by WHO. Currently, routine HIV resistant test is not recommended for at baseline, and also while patient failing on first line of ART regimens. However, because these patients care was done in overseas in well-resourced center, they done had resistant test in which it showed NRTI mutation of K65R and also M184V mutation with integrase mutations. So K65R is associated with intermediate or high resistance to APACC and also TDF, but increased susceptibility to AZT. If you are unable to remember about these mutations, like me, so don't worry. You may just go to this website, stand for INSTI HIV drug resistant. Just enter the resistant, and the result will be available. As I said just now, K65R mutation associated with intermediate or high level resistance to tenofovir, APACC, but increased susceptibility to AZT, while M184V mutation associated with in vitro resistance to 3TC and FTC. As shown here, AZT is a good option because it's increased susceptibility with possible use of TDF for these patients. With these mutations, patient also had resistant high level resistance to albuterol and also raltegravir, with potential low resistance to dolutegravir. So for him, in which he failing on first line treatment of INSTI plus 2 NRTI, the best option based on the mutation is either combination of AZT containing NRTI backbone plus boosted PI plus minus BD dose of dolutegravir. For this patient, he subsequently prescribed of ribavirin, dolutegravir, darunavir, and also cobicistat, and able to achieve virological suppressions. However, 2 years later, he finished his study and back to Malaysia, and his medication is nearly finished, but this ART regimen is not available in our country. So what ART regimen would choose for him? His recent blood investigations were suppressed or rendered with normal kidney function. However, he had dyslipidemia. So choosing ART for him, would you continue the current regime? As we don't have cobicistat in Malaysia, we may switch to ritonavir or change the backbone to APACC containing NRTI plus PIs, or use TDF as a backbone plus boosted PI. So for him, multiple options can be offered to him. As I said just now, cobicistat is not available. We may switch to ritonavir 100 milligrams daily and use darunavir 900 milligrams daily. But in Malaysia, it's a very expensive option for someone who just finished his study and not working yet. And it will increase the pill burden, as we don't have darunavir 900 milligrams in Malaysia. We only have 600 milligrams pill. We may switch to combination of combivir plus ritonavir and darunavir, but still is remain an expensive option. Meanwhile, he also had history of anemia, in which APACC is not a good option, and it also associated with heart dyslipidemia, in which what we notice in this patient. We also may offer a combination of combivir, Calitra, or boosted ritonavir, atazanavir. Based on the resistance test, the patient should suppress with these regimens. But as I said again, combivir associated with anemia and dyslipidemia, and possible increased pill burden with Calitra, because it needs to be taken daily. So after discussion, the patient opted for combination of combivir plus lopinavir ritonavir due to financial issues. So we switched to combination of atazanavir, combivir, and Calitra. However, few weeks later, he presented with significant gastrointestinal side effect, in which he unable to tolerate with current ART regime. So we had decided to switch his ART to TDF based NRTI regime with ritonavir and atazanavir, and he managed to achieve good maintain virological suppression with current regimen. So the question now, can TDF based NRTI being used in the presence of K65R or M184VI mutation as in these patients? So I just want to show one of the latest Nadia study in weeks 99, in which it showed, although we using a backbone NRTI with predicted no activity against the HIV, by combination with high barrier resistant ART such as dolutegravir and darunavir, ritonavir, combination with either TDF or APACC, is still able to achieve the virological suppression despite presence of the mutation. So it's an option to use this combination. Thus, I think sometimes by doing HIV resistant tests, when someone who had failings on first line therapy, sometimes may confusing us to choose what's the best ART for patients. So to summarize our first case, while switching ART in someone with virological failure, first we need to identify the cause of the virological failure, the reason of non-adherence or intolerance, and need to address that before we choosing a switching for ART. Prior switching ART, we must look carefully on the previous ART regimens and any documented resistance, and choose best ART based on patients' comorbidities, expectations, to find the best cost-effective new ART regimes for him and monitor the patients. So I'll proceed with our second case. Here we have Mr. Y. He was diagnosed with HIV in year 1999 at the age of 41 years old. He was presented with VT episode during that time and diagnosed with Wolff-Parkinson-White syndrome. So viral screening was done and diagnosed with HIV, and he only started with combination of Combivent and efavirenz on March 2002. But after 2 months, he defaulted treatment and only presented a year again with thalomycosis and varicose zoster infection over the face. So we had re-challenged him with the same regimen and managed to achieve virological suppressions. However, he started to non-compliance to the ART, and in 2005 he had virological failure, in which we switched the ART from Combivent efavirenz to stamivudine, lamivudine, indalvin, and ritonavir, and able to achieve good virological suppressions and maintain this viral suppression. During this year, he also had multiple admission for hypertensive crisis and managed the blood pressure problems. He had achieved viral suppressions. However, a year later, he had recurrent loin pain, and we noted his kidney function is worsening, and the eGFR dropped to 45, while the ultrasound kidney showed urinary stone. So what do you think happening in Mr. Y? So the worsening kidney functions could be explained by the kidney stone or by the uncontrolled high blood pressure, or possible due to previous amphotericin B exposure before for the thalomycosis. So something about CKD and urinary calculi and also heart. We know that PI, especially indinavir, is not being used in this patient. Atazanavir and darunavir associated with kidney stones as shown in this table. So if someone, patients on PDF-based ART regimes, which may cause tubular dysfunction, we need, and the eGFR droppings, we need to switch to TAF, in which is associated with improvements of the kidney functions of the proteinuria. Besides TAF, APACC is something another ART can be used for someone with impaired kidney functions. So back to this patient, he had a chronic kidney disease with urinary stones, most likely due to indinavir or then what would you do? Would you choose abacavir, lamivudine with boosted lopinavir, ritonavir, or use the same backbone but using a dolutegravir, or switch to TAF-containing regime as here, or using a 2 drugs regimen combinations of dolutegravir plus amivudine. Be aware about the drug-drug interaction of itraconazole and efavirenz for someone who on thalomycosis. A lot of options can be offered. We may switch the patients to abacavir and lamivudine and Caletra, but because it's a BD dose for someone who had history of surgical failure because of non-compliant, it may not a good option for someone who non-compliant because of increasing pills burden. Samo is still a bit expensive in Malaysia. It costs about 500 ringgit currently for such a regimen. Single pill combination of abacavir, 3TC, and also dolutegravir is a good option, but it's for someone who had kidney impairment, but it remains quite expensive, and such single pill combination is not available in Malaysia yet for now. So patients need 2 different pills. Same like TAF-containing regimen. It will improve patients' compliance by single dose, but it's still not available in Malaysia. So we know dual ART regime of lamivudine plus dolutegravir is contraindicated for someone who had history of urological failure. So what would you choose for him? So we had discussed regarding ART switching with the patients, and because of financial issue, we had referred him to medical social workers for financial assistance. However, he defaulted and only presented to us 10 years later with non-typhoidal salmonella bacteremia. He been treated, and we discussed regarding initiation of reinitiation of ART. My next question, although the answer is here already, would you do HIV resistant test? Yes. The answer would be no, because he's not on the treatment, and the HIV resistant test should be performed while the patient's on the failing regimen, or at least within 4 weeks of the cessation of the treatment. It's because while patients are not on the treatment, there's no more selective pressure by the failing ART, thus the HIV may revert to the wild type again, and the wild resistant strain circulating in very lower number thus cannot be detected. So after being treated for the OI, he was started with combination of APACC, lamivudine, and ratutrelvir, and able to achieve good virological suppression. And recently, on 2019, we had switched him to the ratutrelvir to dolutegravir, because ratutrelvir need to be taken BD dose compared to DTG just daily. It will improve patient adherence and with the similar cost for the patients. So on switching DTG, we must aware about some common drug-drug interaction. For example, metformin, it should be reduced to maximum 1 gram daily because of the drug-drug interaction with dolutegravir. So now he came for follow-up. He had he's 63 years old with history of urological failure, with chronic kidney disease, and with high cardiovascular risk. How would you optimize his ART? As you can see here, the Framingham risk score is very high, it's more than 20. So just a little bit about ART and cardiovascular risk. So as we know, APACC, as what patient being using currently, is associated with increased risk of myocardial infections and other serious cardiovascular events such as stroke. It could be due to selection bias, in which most of the people, when they're having a chronic kidney disease, we need to switch the patient from tenofovir to APACC, in which the CKD itself is a predictor for higher risk risk of cardiovascular event. But some postulations say that APACC may be associated with increased stickiness of the platelet, thus lead to increased risk of MI. So certain PI, especially Caritra, darunavir, indinavir, associated with cardiovascular risk, increased cardiovascular risk factor, but not ATV. And it also associated with increased risk worsening lipid control, beside other NRTI such as AZT, APACC, TAF, but not TDF. So recently, a lot of people switched to DTG TAF combinations, in which we can see it associated with weight gain. Either this weight gain is associated with increased risk of cardiovascular risk factors in obesity, it still needs to further to be evaluated. Thus, for patients living with HIV, we need to assess and modify their underlying factor which lead to increased cardiovascular event, such as hypertension, dyslipidemia, diabetes, and smoking, beside optimizing the ART regime. So for this patient who had kidney problems, who with high risk cardiovascular factor and a history of urological failure, beside optimizing his cardiovascular risk factor, what would you do to optimize his ART? Would you just continue the same regime containing APACC, or you would switch the APACC to TAF? Or switching to long-acting injectable cabotegravir and ribavirin, or using a two drugs regimen such as dolutegravir and lamivudine. Of course, I think using APACC is not a good option for someone with a high cardiovascular risk factor with someone with chronic kidney disease. We may switch APACC to PAF, but it still remain slight costly for our patients in Malaysia. And injectable cabotegravir is still not available in Malaysia. This dual drug regimen is an option for someone who had history of logical failure and now had achieved logical suppression. So it can be used for someone with history of N184 VI or logical failure. So as we know, this dual ART regimen is not recommended for use in patients with current or past history of resistance to any component of DTG or 3TC. But for someone who had exhausted ART regimen, is it an option? So these remain questions, but I want to show two studies here in which the first study is SOLAR 3D. Here, for people living with HIV who had history of logical failure or documented HIV resistance, and they achieved logical suppressions of 2, 3, or 4 drug ART for more than 6 months, they switched to dual ART regime containing of lamivudine and DTG, and despite having history of logical failure or mutations, is still able to achieve virological suppression. It's also demonstrated in French AIDS cohort, in which although the patient had archived M184VI mutation, they're still able to achieve virological suppression, and the rate of virological failure is similar for those who not having the mutations. So to summarize my second case in optimizing ART in the setting of virological suppression, so as we can know, a regimen modification may benefit people living with HIV by reducing their pill burden, the cost, and or to decrease the risk of long-term adverse effects of the ART while maintaining viral suppression. To decide what best ART for the patients, a full ART history must be reviewed, including their virological response, how long the patient been suppressed, their past ARTs, is there any toxicities, intolerance, and reason for the non-compliance, their resistant tests, beside deciding their ART based on their comorbidities such as Hep B co-infection, kidney impairments, high cardiovascular risk factors, and others. And after we switch the ART, they need to be close monitoring at least for 3 months after the switching of the ART. So with that, I would, before I'm ending my presentation, I would just want to throw again this question for someone who has history of virological failure with kidney impairment and high cardiovascular risk factor. What best ART regime would you offer to him? With that, thank you. Thank you again for the organizer for inviting me for today's talk. And to my ID team, especially Prof. Iskandar for his guidance, Prof. Adiba, Prof. Minas, and others. Thank you.